Assalamu alaikum. Please, the audience, take your chair. It's my great pleasure to start the second session in pediatric cardiology and to start with Professor Ziyad Hijazi.
Thank you.
Professor Ziyad Hijazi is a well-known figure in intervention and invention as well procedures in congenital cardiology. We learned from him a lot. And in fact, everywhere, international, once you say Z, it means Ziyad Hijazi. Please welcome Ziyad Hijazi. He will talk about the pulmonary valve replacement state of the art by transcatheter approach. So Ziyad, please.
Shukran ya Saleh, shukran. Sabah al-khair, good morning everyone. You know, obviously it goes without saying, it's my great pleasure and honor to be back home. Most of the people here, sitting here, are very close friends. I want to thank specifically Dr. Ali Elhalabi for inviting me and arranging this with me a few months ago. So without further ado, let's talk about the transcatheter pulmonary valve replacement. This is my disclosure slide. So we're going to talk about pulmonary valve replacement. And the question is, you know, why we are talking about this subject. In the past, we used to think pulmonary regurgitation is a benign thing for patients, or PR, don't do anything. But we found that pulmonary regurgitation, especially severe, results in progressive right ventricle dilatation and development of ventricular arrhythmias. And this leads to RV dysfunction and, of course, sudden death. And we know now that pulmonary valve replacement at the appropriate time will reverse these events and patients do better. And now, of course, we have significant experience with a transcatheter pulmonary valve replacement. But before that, if we want to replace a pulmonary valve, we would send them usually like Dr. Bassam or Dr. Youssef or one of the surgeons to replace the conduit. And if they do, usually they would use one of the three things, either a homograft or a cloth tube with a valve sewn inside or the Contegra. Rarely the surgeons, they use prosthetic or metallic valves on the right side because of the chance of thrombosis and for the need also for the patient to take anticoagulation. Doing operations is fine. We all send our patients to the surgeons to do operations, but as these conduits, they don't last lifelong. If you are lucky, they would last anywhere from 10 to 15 years. But actually, I'll show you a curve now. Many of these patients, especially if they are younger, they last shorter. And we send them back again for the surgeon to replace the valve surgically. And each operation has morbidity as well as mortality. So the first operation, usually a mortality of less than 4%, but with each repeat, the mortality can go up to over 13%. This curve is from a surgeon, God bless his soul, he passed away, Jim Twiddle. When he was in Milwaukee, he looked at his 100 patients who received homograft. And as you can see in this curve, that at about 4 years, 25% of the patients required re-intervention. And in red, 50% of these patients already had RV dysfunction because of the valve. So they really don't last 10 to 15 years, but that's what we tell patients, that, you know, if you do surgery, the valve will last anywhere from 10 to 15 years. Obviously, to send a patient to the surgeon or to the interventionist to replace the valve, you have to have indications, guidelines. This is the term for the young doctors here. You need to know guidelines. Why? Because mankind and womankind are greedy. They see something, let's do something. You have to follow the indications. And the indications for this have been published by various organizations, the American College of Cardiology, the American Heart, as well as the European Society of Cardiology. So this diagram here, taking the patients with atrial fallot repair, and we look at all these patients, and the best test that we usually do to monitor the right ventricle size and function is cardiac MRI. And if the patient has at least 2 out of these criteria, then we say that it is okay to go and proceed and put a pulmonic valve. This is in relation to the cardiac MRI. But some of the patients, as Dr. Muhammad Al-Hamdan mentioned, they have arrhythmias, ventricular dysrhythmias, and we look at the QRS complex and the presence of ventricular dysrhythmias. So in summary, we look at by MRI, if the regurgitant fraction is more than 40%, that's important. RV in diastolic volume more than 150 ml, which is almost double the normal. RV ejection fraction less than 40%, normal being over 50%. And if there is no regurgitation, just stenosis, if the RV pressure is more than 2/3 systemic, and you look at the QRS complex, the duration and the shape of the QRS complex. There is something we call fragmentation of the QRS complex. If you have this, these patients are prone for ventricular dysrhythmias and sudden cardiac death. So indications are very important. So how do you assess the PR? There are different ways. I don't want to dwell on this. Physical exam, EKG, echo, CT, MRI, and cardiac cath. And let's briefly mention the echo, which is the gold standard because it's available everywhere. You need to look at the shape of the regurgitant fraction, the width of the jet, the size of the right ventricle, the function of the right ventricle, and all of this. And this is basically short axis views and apical 4-chamber looking at the pulmonary insufficiency. You can see severe PR. And then by Doppler, you can see the reversal flow as dense as the forward flow. Then we look at also the pulsatility of the right pulmonary artery. And that's very important. We call it pulsatility index. Then by the 4-chamber view or modified view, you look at the size of the right ventricle. Echo does not accurately measure the size of the RV, but in the same patient, by the same operator, you can follow these patients and tell whether it's getting larger or not. The gold standard, of course, is MRI. CT is very important. You saw the very nice lecture by Dr. Alessandra Frigiola. CT, you can look at the shape of the outflow tract, the size, the branches, the proximity of the coronary arteries. This is a crucial information because if the coronary arteries are close to the RV outflow tract, putting a metal valve in the RVOT may compress the coronary arteries and the patient can die on the table. So very important. Then of course, 3D printing. 3D printing has become very important for us to print a model, sit with the patient, show the patient their outflow tract, put a valve in there, and explain to the patient as well as to other people interested. And of course, MRI, as she mentioned, is very important. It gives you accurate volume, ejection fraction, residual lesions, you name it. So it's really important test to do. And then of course, cardiac cath. It's not bad to take a patient just for diagnostic cath. Like our colleagues doing PCI, they take them to do coronary angiography, then later they arrange for the intervention. I can do the same thing. So you do hemodynamics, SAT run for residual shunts, as well as, of course, angiography to look at the outflow tract and do balloon sizing and prepare the patient and order the right size valve for that patient because valves come in different sizes and different manufacturer. And these are, so these are angiographies. So you can see the angiograms, large outflow tract, the frontal and lateral. Then we do balloon sizing, and that's the gold standard test in the cath lab. We occlude the RV outflow tract with a balloon and at the same time inject in the RV to make sure that there's no dye going to the pulmonary arteries, and that's the size we are interested in. We freeze the image, measure the diameter, and choose a valve 2 to 4 millimeter larger than this valve. An important test is the coronary compression. You can see here, we occluded the outflow tract, injected in the ascending aorta. You can see the coronary arteries are far and no compression at all. The currently approved valve, we are lucky now, we have many valves, Melody valve, Edwards, Harmony, Venus, Pulsar, Altera, and there is another valve not approved officially, but it's being used off-label called the My valve. So this slide shows you who are our patients. So worldwide, every year there's 1.6 million child born with congenital heart disease. 22% of these patients have problems related to the RV outflow tract. So that's a large number, 350,000 patients. Out of those, there's approximately 30% of those, they would require pulmonary valve replacement, be it surgical or transcatheter. The right side of the slide, my right hand, are the patients who received conduits between the right ventricle and the pulmonary artery. The left side of the slide are the classic tetralogy of Fallot that underwent what we call a transannular patch. They are the majority, 70% of the patients. The right side of the slide, there's a couple of valves good for them, the Edwards valve and the Melody. The left side, you need larger valves, the Venus, the Harmony, the Pulsar. This is the Melody valve, it's the bovine jugular vein sewn inside a platinum iridium stent. And Philippe Bonhoeffer was the first one in the world to do transcatheter pulmonary valve when he was back in Paris. This is the design of the stent. I'm not going to go through the details. This is technical. The valve underwent rigorous studies until finally in 2010 it received FDA approval. The second valve is the Sapien valve. I did the first case in the world in 2005 with the Sapien valve, and we did the Compassionate 3 trial, which I was the national PI, and we received FDA approval in 2012. How do you pre-select your patients? It's very important. You know, you do all what you do from history, physical examination, and as well as, of course, you do echo, chest x-ray, EKG, and then all of these things, right? And then you have to make sure that the patient does not have exclusion criteria, which I will come to shortly. So these are all the tests that you need to do for your patients. Equipment needed in the cath lab, that's important. Do not take a patient to a cath lab and you don't have the right equipment. No excuse. So before you take the patient to the cath lab, you've got to make sure you have everything to conduct a successful procedure and to bail you out from complications. Fail the procedure due to lack of equipment is no excuse. So you have everything that you need. Big list. And these are expensive items. So if you don't do a lot of them, it's unfortunate that they will expire and then you will lose the money. So you need to do more and more cases to use them. So steps in the cath lab, I like to do the procedure under general endotracheal anesthesia. The last thing that I want to worry about during the procedure is the airway. Let somebody else manage that. Anesthesia. Put them down to sleep and no movements, and you conduct your procedure. Get access in the right femoral vein, right femoral vein. Then in the left groin, I do the artery and another left femoral vein. So 3 vascular access. The right femoral vein to deploy the valve. The left femoral vein to do control angiography when I do balloon sizing and coronary compression, and when I deploy part of the valve. The left femoral artery for coronary compression testing. And I'll skip on this here so that we can show you the angiograms better than all this. So this is a patient, part of the trial. You can see here a calcified conduit, angiogram, frontal and lateral. You can see the measurements. In this we do the selective coronaries to see how far they are. Then in this case, we put a landing zone because the valve is short. This is a bare metal stent, a landing zone. زي الطيارة بدك تهدي, you need an airport strip to land in it. So I need to land the valve here. So then, let me just scroll quickly here in the interest of time. So we dilated the stent. Then we put the Sapien valve inside the middle of this valve and deploy it and do nicely. And then at the end, we do the angiogram to test the competence of the valve. So see the angiogram? No pulmonary regurgitation at all, and the patient did very well. Complications, obviously this procedure is risky, just like open heart surgery. Any complication could happen. Stent fracture, coronary impingement, which you don't want. To avoid this, do the pre-assessment. do coronary compression test before. Device embolization, you put the valve thinking that you are in the right location and the right size. You deflate the balloon, it migrates. Unfortunately, if it migrates, most of the time, you need a surgeon to bail you out. On occasion, we can retrieve this valve if you have the proper equipment. We have now a device for retrieving embolized large subjects. We call it the ONO. Okay? Perivalvular leak, that's rare. The most fearful complication is homograft rupture and dissection. And that's why you need to have the right equipment to bail you out. So you need to have stent grafts to cover the dissection and the rupture. And of course, notify your surgical colleague. Tell them that, you know what, before you start the case that day, you let the surgeon know what you're doing, not at the time, so that the surgeons, they will have in the back of their mind that there is a case in the cath lab. In case they need you, you are available. Infective endocarditis is a bad complication. Now with the self-expandable valve is rare, and it is death is the last complication. Look at this patient. He had a Ross and then had Tyrone David procedure, and he had a homograft. He needed a valve. So we did selective coronary arteries, and it actually, on the lateral, it looked like that the coronary artery with the angiogram was a little bit narrow. So we did balloon testing, and I'll show you the angiograms here. So with the frontal, you can see the left main is good. But with the lateral, you can see that the lateral, mild narrowing. So I decided to put a balloon in the RV tract to test. There's the balloon, and with the inflation of the balloon, look at the lateral. It gets narrower. So I was not convinced. So I did IVUS. So I put the IVUS. Let me show you the IVUS. Here is the IVUS. And this is without balloon inflation. And now just let it play. And you can see when I inflate, the left main gets smaller and smaller and smaller. So if I put the stent there, that patient will probably arrest on the table. So it's important that you evaluate the patient thoroughly. So the Melody and the Edwards are for the conduits. For the transannular patch, we have the venous P valve as well as the Harmony. This is basically a list of all available valves to us from Melody, Sapien, Harmony, Venus, Pulsar, and the Altera and the MyValve. The venous P valve, we have the largest experience with this, with now over 3,200 cases worldwide. It's self-expandable, nitinol. The valve leaflets are porcine pericardial tissue, and the valve is covered by porcine pericardial tissue, except the distal 13-14 millimeter. It's not covered, so that you anchor this at the branch PAs so that you will have access to the valve. We did first in human in 2013 in China, and this is the first patient in the world that I did the valve in. Very large. It meets the indication. RV endosteric volume 204, ejection fraction 40%, regurgitant fraction 50%. So meets the indication. So this is injection, severe PR, and on the lateral, severe PR. And you can see the balloon sizing, coronary compression, and then we chose a valve 2 millimeter larger, and we're opening the valve. And then you can see the valve is completely open now. Injection in the RV, it looks good position. The branch is open, and injection in the MPA, no regurgitation at all. So really great valve, and this is the lateral. You can see this. We've done few cases here in Amman with excellent results. We did a clinical trial, a European clinical trial, to approve the valve in Europe. And as I mentioned, now we have over 3,200 patients. Other valves, quickly, Harmony from Medtronic, approved by the FDA in 2021. This is the valve. It comes in two sizes only, 22 and the 25 millimeter. The venous comes in different sizes, from 26 to 36 millimeter. And this is another valve not yet approved from China. This is from Korea, received CE approval just a few months ago. Excellent valve as well. This is the Altera. The Altera is not a valve. It's a device that reduces the RVR flow tract, then you put the Edwards valve inside. So there is the stent, it has no valve, you put it in the RVR flow tract, then you put the Edwards valve. Last but not least, the My valve is balloon expandable valve. So to conclude, both Melody and Sapien valves are balloon expandable, and they are good for about 25% of the patients. The other valves are good for the remainder of the patients. Coronary artery assessment is crucial. Covered stents are essential in such procedures, and the new valves for native RVR flow tract are good. Thank you for your attention for this lecture. Yes, I can hear you.
For the proper arrangement of the program, we'll do some changes. So Dr. Ziyad Hijazi will talk to us about transcatheter closure of sinus venosus ASD. Basically, it was a surgical procedure, but recently Dr. Ziyad and the team updated the procedure, and they are doing it transcatheter, and there is a lot of techniques, and Dr. Ziyad will show us how do we close the ASD sinus venosus. Please welcome Dr. Ziyad.
Thank you, Dr. Abdelfattah. So we're going to proceed now to my second talk, which is a transcatheter repair, I call it, not closure, repair of sinus venosus ASD associated with partial anomalous pulmonary venous drainage, because until recently, actually not even recent, until now, in majority of cardiac centers around the globe, it's still a surgical procedure. But fortunately in our center and a few other centers, this procedure is done in the cath lab. This is my conflict of interest slide. So just briefly about history of device closure of ASD. And by the way, this year marks the 50th anniversary of the first transcatheter closure of secundum atrial septal defect performed by the one and only one, Dr. Terry King from Louisiana. I'll show you his picture now. So interventional cardiology for congenital heart disease goes back to 1966 when Dr. Bill Rashkin from CHOP, Children's Hospital of Philadelphia, did the first balloon atrial septostomy in 1966. Then in 71, Portsman did PDA closure. Then Dr. King said that, you know what, if you can open a hole in the heart and retrieve a broken catheter, why can't we close an ASD? So he started doing animal work on dogs. I'm sorry, animal rights activist. And he proved that you can close an ASD. And in April 8th, 1975, he did the first transcatheter closure of ASD. So the slide on my left-hand side is myself when I was young and happy, still happy, and with Dr. Terry King at the first PICS in 1997 in Boston. And the slide on the right, the same people were switching positions in 2025, August 27th in Chicago, when we celebrated the 50th anniversary of transcatheter ASD closure. And this is the team that did the ASD closure. You can see Dr. King, and Dr. King worked with a good surgeon, Dr. Noel Mills, who supported him. Just like Dr. Bassam Akashi and Dr. Yusuf Zuregat, they support us as interventionalists. Back then, there was a surgeon, Dr. Noel Mills, supporting the interventional cardiologist. And this is the double umbrella they used. Of course, the double umbrella was crude back then, just like the Mercedes of 1972 is not like the Mercedes of 2025. So we came a long way. So ASDs come in different sizes and shapes and locations. The most common is secundum ASD. Then the primum ASD, then of course the sinus venosus ASD. Today I'm going to talk about only sinus venosus ASD, which is basically right here at the corner of the septum, and usually this one is associated with partial anomalous pulmonary venous drainage, usually of the right middle or right upper pulmonary vein. So the vein is stray, تايه, جاي, تايه. So surgical repair has been the gold standard for many years. However, potential complications include obstruction to the SVC, sinus node dysfunction, mortality as well as morbidity. Although in good surgical hands, the mortality should be 1% or less, but you know what? The older the patient, the higher the mortality. Even for secundum ASD, mortality from secundum ASD in older patients is 3%. This is data is from the STS. But things have changed. Now more and more patients undergo catheter repair. So let us visit the story. How did this come only a few years ago? So this picture, myself, and to my right-hand side is a pediatric cardiologist by the name of Dr. Hussein Abdul Wahab from good old Baghdad. So I was visiting Baghdad in 2011, teaching them and proctoring them on different interventional techniques. So he took me on the side. He said, Dr. Ziyad, I can close sinus venosus ASD. I looked at him. I said, come on, man. That can't be true. So I told him, do a few cases and update me. So in 2013, in Frankfurt, at a meeting called CSI, he saw me and he said, I did 4 cases. So I was chairing a session. We finished the regular program and we had 10 minutes left. So I said, Hussein, come up. So he came up on the podium and I told him, please tell the people what you are doing. So he explained that he did 4 cases of sinus venosus ASD associated with partial vein. So of course everybody, wow, wow, wow. A year later, I was reading one of the journals and there is the first report of sinus venosus ASD repair from a guy from India. I said, shit, man. So I called the conference in Frankfurt. I asked them, I need the list of the attendees in that room. So that author was in that room. He heard what Hussein was saying and he went and wrote the paper before Hussein. Scientific theft, without acknowledging Hussein. A year later, another paper from Shaq Qureshi and Eric Rosenthal. The same thing. I called, they were in the room. Scientific theft. So I called the chief editor of the journal. I told him blah, blah, blah. So he said, well, we received these papers, we published them. Let Dr. Hussein write a paper. Short story, we wrote the paper. I did all the نقحت البيبر مظبوط and we sent it and it was published and he acknowledged me in the paper and he wrote the first paper. So this is the concept. See on the on the left hand side of my hand there is the sinus venosus ASD and there is the partial vein. You just put a covered stent to cover the mouth of the anomalous vein so that behind the stent they will drain back to the left atrium and the ASD is there, the device is there to close the ASD. Very simple concept that for decades nobody thought of this except Hussein Abdul Wahab. Ingenious. So pre-selection of patients, of course, echo is the gold standard because you need to diagnose the patient to have sinus venosus ASD, but to confirm everything, CT scan is the ultimate test. We do a CT scan, look at all the veins, where are they draining, and look at the defect, and then if it's good, you go to the cath lab. So this is the CT scan. You can see the anomalous vein coming at the SVCRA junction. We measure distances and stuff. I don't want to bore you with this. We do a 3D model in our center, and you can see it in my hand here. You can see I put a white probe in the anomalous vein behind the stent, and it goes to the left atrium. So I said, wow, so if you put a covered stent there, problem solved. Very easy concept. So this picture here is funny because different ways to skin a cat, because different people use different stents, and because the fear when you put a stent here, let me go back here, this stent here, that this stent here will migrate. Because you implant it here, it migrates to the right atrium. If it does migrate to the right atrium, game is over, unfortunately. Call the surgeon. So to prevent migration, Yunus Boujemlin, who works with me at Sidra, and myself, we developed what we call the suture technique. نربط الستنت بسوتشر وبنطلع السوتشر from the IJ, and we keep our hand on this until we finish so that the stent will not migrate at all. I call it the Yunus technique. So this is the different things. So the steps in the cath lab: access. We get access from the right femoral vein for the deployment of the stent usually, and most of the stuff we do from the right groin. Left femoral vein to do transeptal puncture, so that I go to the left atrium, then through the ASD to the anomalous vein, so that you can keep a catheter in this anomalous vein the entire procedure. Because one of the complications, you put a stent in the SVC, you will occlude this vein. If you occlude it, it's a problem. So to make sure that it does not occlude it, keep access to it. Then I put left femoral artery for monitoring, and then right IJ for deployment of the stent and working the entire procedure. So this is basically, you can see here, balloon sizing. There is angiogram in the anomalous vein. I'll show you even more pictures. Let me just, so TEE is a must. So working with your echocardiographer is essential so that we can tell whether we will occlude the ASD and whether the partial vein now will drain back to the left atrium or not. So continuous TEE monitoring. So these are the steps. So angiogram in the SVC, you can see the negative washout here from the anomalous vein. And then this is the vein, a catheter in the vein. This one is not transeptal. Then we did balloon occlusion. You see, when you occlude the SVC and you inject in the anomalous vein, you can see that the dye, where does it go? To the left atrium. So that's where you want it. Let me just step. So these are, Alessandra, when she gave the talk, she showed all these stents. They are covered stents. The stents that we use most commonly is the 10-zig covered CP stent. The reason we call it 10-zig because you can expand it to 26 to 30 millimeter diameter. The 8-zig stent, maximum 22, 23, and that's not good. The other stent that we use is this one, is the Optimus stent from Androtech, also good. So this is this step here. This is in the IJ. You can see the sheath coming from the IJ. I have a catheter exiting, going from the femoral vein and out the IJ. And that's where we will crimp the stent here. But before we crimp it, we put the suture technique. And just yesterday, or actually the day before yesterday, I modified this technique now. It's not suture. I put a wire, 018 wire, for two reasons. Number one, the wire is longer. The sutures, they come only to 90, 100 centimeter. And number two, you can see the wire. It's really opaque. The suture, you can't see it just in case it breaks or something. The wire does not break to Rumo. And I did a case just the day before yesterday with a patient that Dr. Ali saw for a second opinion, and they came to Doha from Bahrain, and we did him day before yesterday. So this is the stent. We crimp it, and we place it on the balloon, and then we use dry seal sheath 18 French. This sheath here is a dry seal sheath 18 French. The reason is I use the dry seal so that I can open the valve completely, so that when the covered stent goes through the valve, the covering does not get stuck with it. And then you advance the stent here through the sheath all the way to the SVC. And now it is, so now there is the stent. Now, so I have a suture, which you can't see here, but with the new technique that I modified, you can see the wire here catching it, and I can push it down, up, lift it up, down, the way I want. You inflate the stent, and then basically you do all these steps until you are sure by TEE and the fluoroscopy that your stent is in good position and it is all rerouting the pulmonary veins. You can see now the TEE, the anomalous vein, is back to the left atrium. And this is the paper that we published modifying the technique. Not modifying, this is the suture technique. Again, this is another example, large SVC, negative washout, anomalous vein. We did transeptal in this patient. There is the transeptal catheter and the catheter in the anomalous vein. This is the stent. I can lift it up, push it down until we are in good location. And then you inflate it, and the proximal portion, this portion here, you need to expand it to 26, 28, 30 millimeter to close the ASD so that you'll eliminate the shunt. And then finally, you can see here we fillet it open with 2 balloons, and then basically you do a final angiogram in the SVC, it looks good. And in the anomalous vein, you can see that the dye goes all to the left atrium and no closure. And this is chest X-ray the next day showing you the stent in good location. So we've done now over 300 patients. We published this just a few weeks ago. And you can see these are the centers that contributed patients. You can see our center at that time, we had 18 patients. But the largest center is in India, and the second one is in London, and then our center is the third center. And you can see from 2011 Hussein cases, of course no other cases until later on all these cases were done. So this is summary of the data, age range from 4.75 to 86 years of age, weight from 17 to 145 kilogram. 50 patients had bilateral SVC, follow-up anywhere from 1 week to 12 years, and 2 patients have died, one from brain tumor and one from cerebral bleed, not from the procedure. These are the stents used. The majority is the CP stent, and then the second one is the Optimus stent. The implantation technique, suture technique in our center, all of them, and a few other centers did that. Sandwich technique, 2 stents, pulmonary vein protection, ASD closed, so all different techniques for that. Complications, long list. The good thing that there should not be any mortality from this case, and there should not be any sinus node dysfunction at all. But complications do happen, mainly migration of the stent and pericardial effusion and all of this. With meticulous technique, you should not have any complications. So more than 300 successful cases across the world, 2.6% surgery, 2.4% additional procedure. 10 Zig covered the stent is the most common, and new stents are emerging. Obstacles for the wider uptake. The concept, a lot of people, they don't buy the concept. So still, even in our own practice, I have some cardiologists, I argue with them, they don't believe that we should do this technique. But I tell them that this is the future of, of this disease, that we need to do more and more cases, and of course, follow them up and report so that we can see the outcome after 10, 15, 20, 30, 40 years, because surgical outcome now, we have over 45, 50 years of experience. And of course, regulatory approval. These are the centers that have contributed all this. So to conclude, some types of sinus venosus ASDs are amenable for catheter therapy. Careful assessment of the partial vein drainage to the LA is crucial. Results are very encouraging, and I believe most sinus venosus ASDs will be amenable for catheter repair. Different techniques to implant the stent and different types of stents are available. Thank you for your attention.
Thank you, Dr. Ziyad, for this very, very, very interesting presentation, and hopefully we'll have it in Jordan, and we'll keep the discussion till the end, Dr. Ziyad.
Great, thank you.
He's a consultant pediatric cardiologist at Yarmouk University and the Ministry of Health.
Thank you very much, Mr. Chairman. I'm no longer in Yarmouk University, by the way. I'm out. I'm in the private now. Yeah, it was written before, so yeah. Anyway, it's really hard to talk after my mentor, Dr. Ziyad, and especially that the topic is very relevant. My talk is about percutaneous atrial septal defects, closing the gaps and mending the walls. Now, I'll start with the conclusions. 50 years of transcatheter closure of atrial septal defects have achieved great results. Pre-selection of cases for closure is crucial for success of the procedure. Biodegradable devices are achieving promising results. Erosions remain a real, though rare, complication with variable incidences using different devices. Closing atrial septal defects in old ages might need special preparation before the procedure, and transcatheter closure of sinus venosus atrial septal defect is a promising procedure with very good results, though needs special techniques. And I'll not touch on this because this was given by Dr. Ziyad just now. No disclosures. Now this is Professor Terry King. You've seen him with Dr. Ziyad. It was in the same BICS this year in August, 27th of August. And Dr. Terry King, who was the first one who implanted a transcatheter ASD closure device, which is the King Mill device 50 years ago. And since then, it's 50 years now. We have many devices that have been developed. The first real transcatheter device was the ASDDr device, which was started to be used clinically mid-90s, or probably 1995, 96, and other devices now available, the Occlutic, the CardioSeal, Helix device. There are ASD closure devices for multi-fenestrated devices with narrow waist. There is a BFO devices also that have a smaller left atrial disc. Anyway, so these are the devices that are being used for transcatheter closure. The most commonly used is still the ASDDr device, which has been used in more cases in the world than others. Sorry. Okay, the biodegradable devices are developing and increasing in being used. Now, the advantage of these is that no much tissue or material is left in the heart when they are degraded. So there are many trials on that. They are not standardly used now, but in the BICS this year, there was a promising new device that was reported, and probably we'll see some more biodegradable devices being used in humans in the future. And this is one of the old studies about biodegradable devices and their usefulness in the use, especially in BFOs. Okay, now we'll talk about the guidelines for the echocardiographic assessment of atrial septal defect and patent foramen ovale, and that is from the American Society of Echocardiography and Society for Cardiac Angiography Interventions. Now, pre-selection is very important. This is the most important part of the procedure. The procedure will take 15 to 20 minutes, 30 minutes on the maximum if you do proper pre-selection. If you don't do proper pre-selection, it might take 3 hours and not succeed at the end. I'll not talk much about this. This was shown by Dr. Ziyad, different types of ASDs, and what I'm talking about is the ostium secundum defect, really. My main talk is about that. The echo views that we have to take: subxiphoid, apical 4-chamber, parasternal, suprasternal, and high right parasternal, that is in the TTE. And all of these should be done to assess the patient who has an ASD, to get images for proper closure and pre-selection. The flows across the defect throughout the cardiac cycle are important to assess, and the shunt, of course, depends on ventricular compliance, and this or long term can cause right ventricular failure. And well, it's mentioned right ventricular hypertrophy, although it's in very old age. What I always say that volume load only doesn't cause pulmonary hypertension, except rarely, and usually it's an association between the large ASD and a pulmonary hypertension idiopathic. Now, in TEE, we assess the size and shape of the defect, length of the atrial septum, and the presence of multiple defects, and we assess all the rims. We have the rims to carry the device, and these are the rims around. We need to know that rims are adequate. The least important rim is what we call the retroaortic rim, which is shown there. The retroaortic, what is it? The retroaortic rim, which is the least important. We can close defects even with bold aorta with no retroaortic rim. But we have to know all the other rims and measure them and make sure that they are present with a least length. Deficient rims can be assessed by 3D echo with a better visualization than 2D echo, of course. Now, in the world, around 800,000 cases of transcatheter ASD closures done. And that's an estimate, really. There are no studies that can, no registry that can count all done in the world, but an estimate is that the number is around 800,000. 50 to 60% in the US and Europe, 30 to 40% in China and Southeast Asia, and the rest in the rest of the world. Complications of ASD closure are there. They have a low incidence. The most important complication that I'm going to allude on is device erosion, which is an infrequent complication that can occur, but it's really a serious complication. This is why I'll talk about, although the incidence is low, it's a low incidence complication, and the erosion occurs either in the posterior atrial wall, or it might occur in the aortic knuckle. This is has a higher risk when the device is oversized or with no aortic rim. Though we close with no aortic rim, but the incidence is higher, more likely to occur early after deployment. However, there are cases, as I'll show, of late erosion that I'll show later on. This is one of the best articles that discussed cardiographic predictors of cardiac erosion after ambulatory septal occluder replacement. And the thing is that what happens is that the device will erode, probably related to the movement of the heart during the heart cycle and the friction with the wall of the atrium or the aortic wall. Now, as I said, aortic wall deficiency is related to most of the cases that had devices that had erosions. Malalignment also is a high risk thing, and there is what we call atrial wall tenting in the transverse sinus, which is I don't have a photo of that, but it is a sign that we can see during assessment post closure. Now, late erosions can occur. And one of the reports was on a 9-month post-closure. 2 reports were on 12 years after erosions. And the other day I was talking about erosions in front of one of my colleagues, and that it might happen years after closure. And so patients who have transcatheter closure should be followed. The recommendation is to follow for 5 years yearly, and after that they should be followed also and not left without follow-up. And any chest pain is important in these patients, because the start of an erosion will start by chest pain, the manifestation. So any chest pain patients who have transcatheter closure is very important to see the cardiologist and follow up. So the incidence of erosions in Europe. This was published in a study from Europe. Ambulatory device 0.3%, occlutic device 0.03%, and cardia device, which is another device, 3%. There is a difference, although the numbers of ambulatory is much more than the occlutic, but well, probably the difference in metal amount and consistency can explain that the incidence is less of erosions. Now, this is the point that I want to talk about now is closing ASDs in older age, because this is a unique group of patients that might need preparation before doing the procedure. Some of the patients had a higher risk of new onset atrial fibrillation and migraine than controls without ASD. This is why we need to prepare these patients. Now, this second paper, talk about fenestrate transcatheter ASD closure in adults with diastolic dysfunction and or pulmonary hypertension. And in conclusion, partial ASD occlusion in patients with diastolic dysfunction or RV dysfunction and or pulmonary hypertension is safe and may be better tolerated than complete ASD closure in selected patients. So if you have diastolic dysfunction, then probably you can close the ASD partially as a stage rather than close it completely. And you need left ventricular conditioning in the elderly patients to prevent congestive heart failure after transcatheter closure of atrial septal defect. In this study, they compared patients who were given dopamine, milrinone, and furosemide for 48 to 72 hours before definitive ASD closure with device, and they found that they did much better after closure because the left ventricular function improved and accepted the amount of blood that is coming to them much better. And in this study, transcatheter ASD closure is beneficial for elderly population since it improves functional capacity, biventricular dimensions, pulmonary pressure, TR severity, and PNP. However, the incidence of atrial arrhythmias did not change significantly after the intervention. And this is very important because when we treat ASDs, we should notify the patient that arrhythmias might not disappear. Even they might improve, but they wouldn't disappear, especially in older ages. Okay, now this is about transcatheter closure or repair of sinus venosus, which Dr. Ziyad gave a full lecture about. I'm not going to talk about. And Dr. Ziyad talked about the different techniques to anchor or to hold the stent from above. So in conclusion, again, 50 years of transcatheter closure of atrial septal defects have achieved great results. Pre-selection of cases for closure is crucial for success of the procedure. Biodegradable devices are achieving promising results. Erosions remain a real, though rare, complication with variable incidences using different devices. Closing atrial septal defects in older ages might need special preparation before the procedure. Transcatheter closure of sinus venosus atrial septal defect is a promising procedure with very good results, though needs special techniques. Thank you very much.
Our next speaker is Professor Iyad Amori, consultant pediatric cardiologist at Jordan University Hospital, and he is going to speak about battery perfection, coarctation, and PDA advanced therapy.
Thank you very much. Thank you, Munder, for the introduction. And thank you, Ali, for inviting me to give this talk. And I was really humbled by the title of the talk. It was Pathway Perfection in PDA and Coarctation. So two big topics in congenital heart disease in 20 minutes. So it's kind of a hard job to do, but we'll try to go through some interesting cases. So introduction, what we do is not always perfect. It's actually rarely perfect, what we do in the cath lab. Perfection is the enemy of good in many things, and especially in congenital heart disease, whether it's surgical or whether it's interventional therapy. So the core message that I will try to convey today is to achieve the best possible outcome through standardized patient selection, procedure technique, and post-procedure management. So several cases to be presented. Hopefully we'll make it interesting. So we'll start with the patent ductus arteriosus. The PDA spectrum is really huge, although most PDAs are conical like this one, but there are other types of PDAs like a window shape PDA, tubular PDA, or complex ones. And it's nicely classified by this image with most of them, as we know, is this one. So the conical shape PDA, but the shape of the PDA actually dictates the device and the closure that we need to do. So other important variables in each patient with PDA is the patient size. We can do from premature babies up to adults, patient weight from 1 kg and above. Hemodynamics, simple PDA hemodynamics versus PDA with pulmonary hypertension, anatomical variables, and also available devices at the institution. We have too many devices for PDA, designed for PDA. Those are only some of them. We've used coils before, but now it's rarely used. But also there is another coil called net-occlude. We have the usual PDA device that we all use. We have the ADO2, which is double disc device. We have vascular plugs. We have the Piccolo for the premature babies, and we have the Medtronic vascular plug for premature babies also. And don't forget that there are other devices that can be used for PDAs, particularly for special PDAs. We have the muscular VSD device, can be used as off-label. We have the multifunctional device, and even ASD devices can be used for some patients, although it might sound strange, but it can be utilized. So proper device selection when the PDA is unusual, it requires multi-plane imaging, and the general guide for conical PDA, we almost always use the ADO1, which is the single disc technique. We have many companies do that. Tubular PDAs, we have the ADO2 or vascular plugs, double disc devices. For the large window we like to use muscular VSD devices. For the complex ones, you can use plugs, etc. But always remember, some PDAs remain surgical, and some PDAs should not be closed. So this, I will start with the smaller babies. So this is the Piccolo device, which is kind of now like الموضة حاليا, a very small device for the premature babies. And this was our first patient in the in University of Jordan. Those procedures are different from the standard PDA procedures because you only have to do venous access only, and you have to depend on echo for much of the procedure. Because once you get into the PDA, you can see that this PDA actually has a spasm in it, so it's much smaller than what we measured by echo. This is another image just outside, only venous access. You have no arterial access to make sure you're in place, and this is the deployment process. And this is after release of the device. And echo is very vital in controlling this procedure to make sure that there is no complication, no occlusion to the left pulmonary artery or the aorta. And actually, some centers now do it exclusively with echo without the need for angiograms. The older infant, this is the angiographic profiling is really everything. So you have to have, in most patients, arterial access, and I really prefer this, although some operators do it with only venous access, but when you go across the PDA, sometimes it changes morphology and it changes size. An off-angle angiogram is the most common cause of missizing. So you really need to see it before you start closing it. Stability before release is important and always confirm with angiography. This is what we all like to see, the usual PDA. It's not so small, not so large, and it's actually a conical shape. You can measure the narrowest angle here, and then you can measure the ampulla. And for this one, we all use the usual device, which is a single disc PDA, a DO1 from many companies. And you see here that there is a good final image. Sorry, it didn't play. Some anatomical challenges have to be taken in mind. This patient came to us with a respiratory infection, and chest X-ray showed a huge right lung, and it was thought that he had lung collapse in the left side, but actually he didn't have lung collapse. He did not have a left lung at all, and he did not have a left bronchus. This is the right lung on the CT scan. Posteriorly, there is no right bronchus and no left bronchus and no left pulmonary artery. So, and he had also a large PDA, and that was somewhat strange. But there is a PDA even in the absence of a LPA. So what to do with this patient? Of course, we need to take him to the cath lab. So what's the difference? The difference is probably the angulation. So here the RAO projection was much better than the lateral projection, and we knew that from the CT scan. So this is a significant PDA on the RAO projection, and this is the closure with an Occlutech 8.6 device. And the pulmonary pressure she did not have pulmonary hypertension at the time. So another challenge, if you have a device selection error. So this is a patient that we did. She had a longitudinal ductus here. So it's a tubular ductus, but we thought there is some narrowing here at the pulmonary end. So we started deploying an Occlutech device, an 8.6. Here it looks actually reasonable. There is some part of the device in the pulmonary artery and some part in the aorta. And here after release, and in a few seconds after release, it embolized. So we had to retrieve it from the aorta, which is really a pain because you need a bigger sheath in the aorta. So always identify the ductus and select the device based on the ductus. So this is the same patient. So we went back in, and two views, as you can see, there is a long ductus here. And we selected an ADO2 device, a 6.6 ADO2. It's a good device because it has a disc on the right and a disc on the left, and it can elongate as long as the ductus will take. So this is the final image with the closure device. This patient also had a large muscular VSD that was subsequently closed also in the cath lab. So this patient had multiple devices in. Another challenge when you have a hemodynamic challenge. So this infant is a 3-kilo child with a Down syndrome. She's on congestive heart failure, and she has a significant pericardial effusion. So came to the cath lab, put a pericardial drain here. So pericardial drain before we started the procedure, and this is the ductus. And it's a large ductus, measured 3.5 millimeters. but the ampulla is only 7 millimeters. The aorta is about 5.5 millimeters. So if this was a larger kid, I would have used a 6.4. Most of us will have used an 8.6 device because it's a 3.4. But that will be too big for the aorta, too big for the ampulla. So we decided to go with a smaller device, but just moved carefully. This is angiogram during deployment, and this is deployment very slowly and meticulously. Make sure that the disc is within the ampulla, but not to pull too hard because it will just pull to the pulmonary artery. And here you can see that it took the shape that we wanted. And this is the angiogram. The disc is within the ampulla, slightly protruding to the aorta, and the larger, and after deployment, it was good. So the pitfall here is to avoid the obstruction to the aorta and avoid obstruction to the LPA. So that was a successful procedure, and the child really improved significantly. Last one with the PDA cases is when you have a pulmonary hypertension or a hypertensive ductus, not necessarily pulmonary vascular disease. This was a 3-year-old child who was actually referred by Dr. Salaimi, who was probably here. So he had a very low gradient across the ductus, but it was still left to right shunt. Started sildenafil a few days before the procedure. And this is his ductus. It's really large, short. The pressure was almost systemic, just below systemic. It measured 8 millimeters, so it's a huge ductus. But the correct selection of the device is, in this case, would be a muscular VSD device. So we selected a 12 millimeter muscular VSD device. As you can see in this image, this is the deployment of the muscular VSD. It's a nice device because it will foreshorten, because there is a disc on the right side, so it will not be protruding in the aorta. And before I release the device for hypertensive ductuses, I always measure the pressure. Sometimes I do balloon occlusion and measure pressure, but most of the time, if it's a young child or adolescent, I'll just go ahead and close it and measure the pressure before I release the device. And in this case, the pressure actually went down to 45/20 just by putting the device in without even complete occlusion, because the complete occlusion will take some time to happen. There is still some residual leak, but the pressure has improved significantly. And 8 months later, the child is off the sildenafil and he has a normal pulmonary pressure. So I'll move to the coarctation of aorta, which is a totally different topic. So coarctation of aorta is not only a simple obstruction of the aortic arch, and I'm going to focus only on the adolescents and adults with coarctation. We will not be talking about infants and small children with coarctation, just for the sake of time. So it comes in different shapes, and we like to see this one, which is the perfect one for intervention, but most of them actually do not come like this one. So they come either very, very tiny coarctation with hypoplasia of the isthmus. You can see coarctation with more a longitudinal coarctation with dilatation, post-stenotic dilatation. You can see arches with apparent subclavian artery like this one, etc. So this is one variable, which is the anatomical variable, but there are other variables like age and the size of the patient, the associated anomalies, the function of the left ventricle at the time of diagnosis, the anatomy of the coarctation, obviously. So we'll go through a few cases that have been interesting. So the excellent outcomes comes from this pathway. So patient selection and evaluation, pre-procedural planning is really very important. Procedural optimization to have everything ready for you in the cath lab. Residual gradients, we try to avoid having a residual gradient, but sometimes we will accept some residual gradients. Vascular injury and complications, try to avoid them, and if they happen, try to treat them and be ready for them. And consistent follow-up, and we'll see some examples of each of these points. So this is the ideal one, the one that we all like to see as interventional cardiologists. You know, a discrete coarctation in an area where you don't have any hypoplasia of the arch and you don't have any other complicating factors. And this is two angiograms in different projections, and you can see the coarctation. We measure it. We measure what the size that we want. For this one, almost any stent can work, covered or non-covered, but I usually use a bare metal stent for things like this because it's not very tight, and it's usually it has a very good outcome. So for this patient that I did 2 weeks ago, We use the Gore open cell stent that I have. It's an endoprosthesis dilated to 14 millimeter, and that's the result that you can see. Seamless stent, really very thin, and it looked very nice angiographically. What happens when you have a much tighter lesion? This is a young man with a very tight lesion. Here the injection below the arch, below the coarctation site, almost nothing goes through. And this is once I crossed with the catheter itself actually occluded the lumen. So the lumen is here, almost occluded by the 6 French catheter. So what do? We go for this one with a covered stent. It's a mistake if you go with a bare metal stent, because you might actually injure the wall and you'll have extravasation. And always use a covered stent in such patients. Always use a long sheath, and always use a stiff wire. This is inflation of the stent. And because of this patient, the balloon on the stent had still waste, so we used a high pressure balloon, which was an Atlas balloon, and this is the result. Now we have another complication, another patient with a complicating feature, which is a total atresia, total discontinuity of the lumen. So this patient came to me after she was diagnosed with a severe hypertension, and she had a CT scan done outside, and she had a total interruption of the aorta. But this is not interrupted aortic arch. This is aortic coarctation with secondary atresia with time. It just, there is no luminal continuity. So what do we do this? How do we do this? And how do we go around this? So one way is to go surgical and put a surgical repair. But this patient, after studying the case, we decided to go with the transcatheter repair of this patient. And so to prepare for this, it needs a careful planning. So in this patient, for example, we had to have a radial approach and a femoral approach. So you can see here a catheter coming from the right subclavian artery. This is the end pouch, and this is the distal segment. And there is a separation of about 7 millimeters between the two. So we tried to cross with a coronary wire from above. We couldn't. We tried to cross with a stiff end of the coronary wire from above, but also we couldn't. So we had to use a transeptal approach, a transeptal needle, to perforate through. So we stained, this is the stain of the contrast here. We stained it on purpose so we know where we are, and we have a landmark to go through, multiple planes to make sure that you're perforating in the correct direction. And this is after perforation with the needle. We place the coronary wire. You might see it. It's actually around the arch, and then quickly pass the 4 French catheter over it, and then a stiff wire, and then we put the stent. And this is the covered stent. Obviously, you have to have a covered stent in this patient. So for my own benefit, I did not want to release the waste on the stent, so I planned a second procedure in 2 months, just to avoid injury to the patient and to myself. So 2 months later, so this is the initial angiogram after 2 months, and then we used an Atlas balloon to eliminate the waste on the stent, and that's the final result with minimal waste on the stent. So challenge of an old age. So when you have an old age with coarctation, that might give you a little bit of more challenges, which is, the aortic wall, the calcification, and the risk of aortic rupture in those patients. So what's different? I think in old age, I would rather go with a covered stent, not a bare metal stent in any case. So this is a 62-year-old with uncontrolled hypertension, and we found that she had a severe coarctation also with minimal flow across the segment with a lot of collaterals. We used a Bentley stent that was available at the time, and we inflated the stent. Always go with a slow and steady inflation. Don't try to inflate it too fast. We used to do that in the past, but actually stents tend to embolize if you do it fast. So we go with a very slow inflation, and this is the end result of this patient with almost no gradient across. So now I think this is another case that demonstrates the need for follow-up. This child actually presented to me when he was 3 years of age, and at the time he had coarctation, and he had also an LSVC to the left atrium that we closed with a vascular plug, and also we balloon dilated the coarctation at the time. At the age of 12 years, he had a stent placed a stent, CP stent, bare metal stent in the aorta, and follow-up CT done after 5 years showed aneurysm. So he had an aneurysm.
Dr. Iyad, 1 minute, please.
1 minute? Yeah, we're almost done. We have an aneurysm, as you can see in this image. And also there is a stent fracture. So we decided that he needs, and also some hypoplasia of the isthmus. So he needs another stent to be placed to cover the aneurysm and also to treat the hypoplasia of the isthmus. I consulted with Dr. Ziyad at the time, and we decided that it's better to put a longer stent. But we will sacrifice the left subclavian artery. So what we did is actually we approached the left radial artery and put a catheter there, trying to perforate the stent that we just put. But no matter how I tried to perforate the Gore-Tex, I could not. So I accepted the result with suboptimal result. The patient had some left arm numbness for a few weeks after the procedure, but then his blood pressure actually went up in the left arm, and he's fine now. So in this patient, suboptimal result is accepted. Unusual presentation, this is from Dr. Mahmoud Abbad. In a 15-year-old, he called me a month ago that he had a patient who had endocarditis, positive blood cultures, and when he did the echo, there was severe coarctation of aorta. They treated the patient with IV antibiotic for 6 weeks, and she's been infection-free for the past 1.5 months. CT scan was done at Al Bashir Hospital, and it showed also an aberrant right subclavian artery. And also, when I reviewed the CT scan, there was a pseudoaneurysm at the site of the coarctation. It's a native aneurysm, not because of any intervention. So yesterday, actually, this was from yesterday, I took her to the cath lab for the intervention, and this is the angiogram in the arch. And this is another angiogram showing that there is a tight coarctation, and there is a big aneurysm, a pseudoaneurysm and I think this probably has happened because of the infection. The infection was probably there, weakened the wall of the aorta, and resulted in this aneurysm. So just to be a little extra careful, so I did, I left a coronary wire up around the arch, and I went into the aneurysm with a 4 French catheter and just to inject it, and it's a significant aneurysm. And just a couple of images, and this is the right subclavian artery that comes from below the coarctation. So her blood pressure in the right arm is not reflective of her blood pressure in the head or left arm. The left arm was the highest. And also what's important with this image, the blood flow to the subclavian actually comes from the collateral. So I would sacrifice this right subclavian artery because there is no other way around it. So what should we do? This is the measurements. We need a stent that covers the coarctation and covers the mouth of the aneurysm, and also it will jail the right subclavian artery. And that's what we did with the longest CP stent that we had, 39 millimeters. Put on a bib balloon, 14 millimeter, and then we had to just balloon dilate to flare it down because there was still some flow into the aneurysm from here. So we just flared it with a 16 millimeter Atlas balloon. And, sorry. Can you play the last one? So it obliterated the whole aneurysm. So this was the last case with the good results treating both problems. And I think this is the last slide. So in summary, the 5 P's for procedural best outcome is precision in diagnosis and patient selection. Planning, meticulous pre-procedure planning is very important, and also having everything ready in the cath lab. Performance with flawless procedure execution. Take no shortcuts. If you need another angiogram, just do another angiogram to make sure that you delineate the anatomy very well. Prevention of complications proactively, but also have everything ready in case you have complication. You have snares available, you have bailout stents, covered stents, etc. And persistence with lifelong follow-up, because those patients are what we do is most likely not a perfect procedure, so they need a persistent follow-up to look for complications. That's it. Thank you.
Thank you, Dr. Iyad. I think we have some delay, and we are apologizing for Dr. Roberto Ferrari because the time now for the Jum'ah prayer, so we'll postpone his presentation till 2 p.m. We have 5 minutes discussion for the speakers, and we can open the floor for the questions.
Question for Dr. Ziyad. You asked about the durability of the pulmonary valve. People nowadays they talk about the stem cell technology regarding these valves.
Thank you, Dr. Aouni. So the question is about durability of these transcatheter pulmonary valves. So the answer, the first transcatheter pulmonary valve done was in 2000, and some of the patients, they have good long-term follow-up. The first valve with the venous I did in 2013, and the valve looks like as if you implanted it yesterday. So I tell the patients the same durability as surgical valves. It could be better, but obviously the larger the valve that you implant, the longer these valves last, right? So that's what I tell the patients.
Dr. Qais?
Thank you. It's actually a follow-up on Dr. Aouni's question. Any specific follow-ups for after you do the valve? Other than, gradients and regurgitation, anything in particular?
Yeah, so we, obviously we follow them by echo, physical exam echo at 6 months and at 1 year. And usually at 1 year, if I put the valve for regurgitation, I do an MRI to see how much reduction in the RV volume. And that was part of the trial that we did. But I think it's a good practice to document your follow-up improvement by MRI.
Okay, thank you.
But they require lifelong follow-up, once a year, echo, EKG, and then go from there.
Dr. Yusuf Zirgar, تفضل.
Professor Ziyad, we always look forward to attend your lectures to look for the forward updates. I have two concerns, actually. The first one is the growth potential if you applied this stent in a lower age group, and if these stents are expandable or not in future in case. The second concern is there any the SA node problem down the road, I mean in the follow-up of this.
Great.
Thank you.
Thank you, Dr. Youssef. So the first question is growth potential. First of all, we should not put these stents in a growing patient unless if they have achieved SVC adult size. And if you look at the growth and development, SVC final adult size can be achieved when the patient is about 6 to 8 years of age. So I would not put any stent in a younger patient like this, because if it requires enlargement, you don't have anything to protect the anomalous vein, so you go and enlarge it, you may occlude the pulmonary vein. So any patient that we will do, minimum size of the stent should be 16 to 18 millimeter diameter, which is adult size. The second question, at least from my personal experience now, about 25, 26 cases, we have not had any patient with sinus node dysfunction. The data that I presented with over 305 cases, only a couple of cases sinus node abnormalities, but none of them required any treatment. So we believe that it is going to be better than open surgical repair for the sinus node dysfunction.
Okay, by this we conclude our session. We thank the speakers and the audience, and we will have now a prayer and lunchtime, and we'll meet at 2.
الصلاة راح تكون هون يا جماعة في نفس القاعة هاي.